Hello, Rob Lejeune and Brandon Smith here, talking about denture design. Starting in the clinic with there are some different object types you can scan. Obviously, we all know you scan the teeth and the soft tissue. Of course, that's an obvious one, but you can also scan an impression and you can also scan a stone model if necessary. And there could be some different reasons to do so with your denture workflow, so we'll talk about that. And then we're also going to talk about tooth library setup and just finding some efficiency in your denture design with tooth libraries. So, Brandon, let's jump in. Let's talk about object types in denture workflow and what are the reasons why you would use some different object types to begin a case.
Yeah, definitely. So, in your Trio software, you're going to have three different object types when you choose a denture as your restoration type. The first is just going to be your intraoral scan, so you can take that from directly from the patient's mouth. They can have teeth, they can be completely edentulous. Either way is fine. The next would be your impression scan. So this one is a little bit more confusing for a lot of people because there's some misconceptions about what you can use it for. So most people think that you're going to use it for, taking a physical impression of the patient and then scanning that impression, which is true. But there's another use for it that really helps us with dentures, and that's scanning an impression inside of an existing denture.
Yep.
So the part of the reason that you would ever want to do this is that denture gives us a lot of information when we're trying to design these cases. It tells us the original tooth mold shape, the size of the teeth. It gives us a better bite. Trying to set up wax rims or use some kind of a mush bite or a large, centric tray or something like that. It's really difficult to see with those if the patient bites together correctly, just because you can't see anything but that bite tray or those wax rims. So using a denture as an impression tray is a great technique to give us a lot of information. It's also basically like using a custom tray because it fits that patient's arch form and everything, so you're not, missing information, typically in the borders or on the post-palatal seal areas, which is really nice. And then the last option that you have in there is the reference denture or copy denture option. So that one is primarily only used if you want to scan in an existing denture and just make a duplicate of it. You can use this option too if you're going to copy the denture but also change the fit. So if you take a wash impression in it, you can still scan it full 360, and you can make that exact denture just with a different fit. Now, the only time you wouldn't want to do this is if you're trying to switch out the teeth. So if the teeth are
Yeah.
heavily worn, you wouldn't want to use this option. You'd want to start over from scratch at that point.
Yeah, there is a distinction between a copy denture workflow and a reference denture workflow, right? Copy denture is more of like a one-to-one copy of an existing denture. You do not get the ability to select a new tooth library with a copy denture workflow, right?
Right.
With a reference denture workflow, you're using the old denture like a custom tray. You could open the bite, you could select new teeth if you want, and you're basically making a brand new denture with the existing vertical and the existing bite, or you could open it a little bit and then select new teeth and go from there.
Yep.
Awesome. All right, let's jump in.
All right. So I'm going to show my screen here, and there we go. So one of the other things that's a little different, most workflows that we've seen with this system are typically using a desktop scanner, scanning them, and then running through a design, which is, one way that you can do it. But one of the harder workflows with a little bit more steps is when you're taking anything from an intraoral scanner and bringing it in, because there's some things that are missing. So the lab scanner does a lot of extra things on the side, or I'm sorry, the desktop scanner. It creates a watertight model. So this what you see here on the screen, this is a watertight model, meaning that the bottom of the scan is not open. It's not a shell. It's a full boxed in model.
Yeah.
An intraoral scanner doesn't do this. So one of the things that the dental system software has to do when it's working on these is it actually has to create this inside the software. So this entire prepare step here that we're on the left hand side here, this is basically kind of like your model step. So we're taking these shell scans. It could be a shell scan from an intraoral scanner. It could be an impression scan from an intraoral scanner, and it could be a reference denture scan where you're using the existing denture. In this case, we've taken these scans from existing reference dentures with impressions in them. So one of the first things you have to do with these is you have to refine the scans. So a lot of times, when you're going from like a trio scanner into dental system, it's not that big of a deal. Most of the time those scans are already post processed when they come into the dental system software. The problem though is that when you get scans that come from other intraoral scanners, they have to be converted into a different file format. So you're typically bringing in STL files or PLY files. Now, the problem with that is in these intraoral scanners, they take a really high quality image and they have to basically downgrade those to a lower quality image so that they're open and can be accepted by other systems. So this would be an example of going from like your Dentsply scanner or your iTero scanner into 3Shape. So they convert these scans down to their raw formats in either an STL or PLY format, and then you can import them in. And then once you import them in, they're reconverted into a DCM file format, which is 3Shape's proprietary file format. So these scans change type 3 times in this process. Now,
How does that affect scan resolution?
it affects it actually quite a bit. So in the background on a lot of these intraoral scanners, what happens is they do a few things to the data once it's compiled. So you'll notice, when you scan on any intraoral scan, it doesn't just show the image right away. It has to process that image and then it creates this 3D model on your screen. Well, in the background, what it's doing is it's analyzing each individual scan that you took and it's stitched together, and it's getting rid of duplicates, it's filling holes, it's cleaning up the scan data a little bit, and then it's giving you this nice crisp image of that scan. What happens though is then when you export those and you create STLs or PLYs, a lot of this background data and refinement that these scan softwares do is lost. You end up with the raw data, which is not always very pretty. It's got a lot of holes in it. It can look pretty bad, even though in your intraoral scanner screen everything looks great. This was one of the big issues with probably 10 or 15 years ago when Sirona was big, and they would make these scans, and the scans would look great on the doctor's screen, and then you'd send it to your Crown and Bridge lab, and then the Crown and Bridge lab couldn't see the margins because they weren't using the Dentsply software to design. They were using 3Shape or exocad or some other system. And it's kind of the same thing in dentures. It's just not as prevalent because there's no crown prep, there's no super sharp edges, there's nothing that can really show you that there's an issue unless you look at both scans side by side. So one of the things that has to happen when you bring it into dental system is if there's a bunch of scan artifacts and missing data and errors in the scan, if I try to just design on that, I'm going to have all kinds of problems. I won't be able to draw my outlines for my bases. It won't adapt to the scan when it creates the base. There will be all kinds of issues. So what this refine step does is it actually looks at the scans and it tries to do what the intraoral scanners did in their software, which is remove duplicate data. It tries to close holes. It tries to eliminate scan artifacts, and it tries to clean up the border so it's a little bit easier to work with.
So obviously a trio scan into dental system is going to have all of that data preserved, and you're not going to have as many steps for cleaning up the data. So
Right.
outside of Trios, what would you say the best scanner data or some of the top two or three scanners that you see that have good compatibility with 3Shape dental system for denture workflow?
Well, it's kind of hard to say because again, you have to dumb down those files. So once you dumb down those files, they're all pretty much the same. I will say, as far as workflow goes, Trios probably has the best workflow, but Itero also has a really nice workflow for a dentulous, and I believe Sirona does as well. If you're going to dumb these down and convert them, the best file format to go to is PLY. It preserves a little bit more of the data. You get the color still, and it holds on to things like annotations and stuff like that, which is helpful.
So the PLY file is a format the doctor can save it as at the time
Yeah.
of scanning. And if he sends you a PLY file, that data is going to be better than if he sends you an STL file. That's what you're saying?
Yeah. Yeah.
Cool. Awesome. Makes sense. Let's keep
So,
rolling.
with this refined step, if you are bringing in a reference denture scan or an impression scan, you want to make sure that this impression box down here is checked when you refine this. If it's just an intraoral scan of the oral cavity or a scan of a model or anything like that, you don't want to check this off. It basically just tells the software that, hey, this is an impression. It's not a positive model, so it knows to invert those over to a positive surface on the impressions. So you always want to select all. You will sometimes get a error in this step on the improved scan borders. So you can see on this scan, the whole palatal area is not in the scan data. Typically, if you're going to do a reference denture scan, you want to not have that data there. This will give us the tooth information, size, position, and shape, and everything like that. But there's no real benefit to completely scanning the entire thing.
So
So
you're just getting the size, length, midline of the teeth, but now you have the scan of the actual palate.
yeah, yeah. So this had an impression taken in it. You can also see here how it was trimmed back. So
Yep.
this is about what you want that trimming to look like. If you put the impression material over the teeth, it's going to be harder for you to see
Yep.
the shape and size of those teeth and help you design it properly. So you always want to make sure after you take your impressions that you trim everything back so you can see the original denture real well.
So that you trim that back physically in the reference
Yeah.
denture, but the data trim you did in the palate side here, did you trim that in the iOS scanning step or in the dental system step?
You would do this in your iOS scanner.
Okay.
So basically what will happen is the way that you do this scan path now, this is Trio, so other scanners could be a little different, but you scan the whole intaglio first, and then you roll to the outside and you scan the buccal, and then you get up on the incisal edges and the occlusion of the teeth, and that's all you need. You can trim away. All the trimming does is it helps with this improved scan borders refinement here. If you leave it kind of looking like Swiss cheese, then it's going to have a little bit harder time. It's going to take a little longer. So it's always a good thing to make sure that you manually trim as much away that you don't need as you can.
Yep.
Now, if you're scanning like a intraoral arch, you want to leave as much as possible because you need all those soft tissue borders to create that cohesion on that denture. Usually what ends up happening is people trim away too much or don't capture that data, and then the borders all end up short.
Makes sense.
So these two steps are similar. The refined steps, they you just do each arch one at a time, and then you'll come into this occlusal alignment step. What this actually does for the software is it tells the software where the occlusal plane is. What it really uses this for, though, is it uses it to tell the software how to close the bottoms of the scans to create those models. So, for example, if I were to set this like this, then the bottoms of my scans would close parallel to that. So I
Gotcha.
would have these crazy angles on my bases here. So you do want to make sure that you get it as close to aligned with the occlusal plane as possible so that both of the bases are parallel to that occlusal plane.
Makes sense.
Then you have your trimming steps. So with these trimming steps, what you'll want to do is trim away the excess. So you're going to trim about 1 to 2 millimeters above the border or the roll of the impression material. And this is just to create the digital models. Once you've created those, you'll actually get a slider back that gives you the teeth. So you'll always have those teeth to help you set when you get into that step later on. And then in the post-palatal seal area, I usually try to take it right along the back edge border of that impression material so I get that full extension back there. And then kind of the same thing here with the lower. You'll get...
This trimming you're doing all right here is for the model, right?
Yes,
For the virtual model. Yeah.
Yeah, it's to create that virtual model.
Wonderful.
And you can also see here on this scan where the linguals underneath the teeth were not scanned as well. And it was trimmed away. Now, when you are doing this in your intraoral software, you want to be careful not to trim too close to the border, though, because you want that extension back here. If you trim all this away, then you won't have any extension. Your border could be short on the linguals. And I use the same concept here, about 1 to 2 millimeters above that bottom of that impression material, and that usually gives me enough material to design these. And then these last two steps, these are sculpting steps. So if your impression material has, bubbles or anything like that in it, you can use this step to eliminate those and clean up your denture model here a little bit nicer. But you can see basically it stops right at where I trimmed it. So I've got this nice extended model out here that I created all virtually. The base is nice and parallel kind of with the ridge and where those teeth were. So I get a nice model here.
Nice.
And same thing here with the lower. Also, one other thing I'll mention here is if you're doing a immediate denture case, this is also the step where you'll extract the teeth virtually as well and shape the ridge a little bit if you want.
Yeah, so by scanning the reference denture impression, you get all the accuracy of the scan data. You're eliminating any inaccuracy of stone expansion or any of that. You get your border extensions. Then you also get your teeth for your midline, your lip support, all that. So, I mean, I would call this one of the best digital denture workflows, really, in the world of digital dentures. It saves the most time, it's the most accurate, it's the most predictable on so many fronts, this reference denture workflow. If a doctor doesn't have this in their repertoire, they are really missing out on efficiency.
Yeah. Yeah, and this is so much easier than any of the other workflows as well, just because on one of the hardest things to capture when you take impressions, either physically or digitally, without this is the bite step. So with these and the bite step, what you can do is you can place these back in the patient's mouth, and you can actually put some blue mousse bite material between them, have the patient bite together, and then you take the dentures out and you just scan your buccal bite shots and you're done. So it gives you a lot easier of a way to capture all the data that you need.
Yeah, if you want to open the bite a little bit, you just do that.
Yeah.
But then you pull them out in occlusion with the bite registration material in there. You take a new scan, and now you're going to have this perfectly preserved bite. You didn't even have to take the blue mousse off and refit it. It's just it comes out as one object, right?
Right.
That's amazing.
Yep. So I'm going to skip over a lot of these steps. These are just basically setup steps to get you to setting the teeth. There's tons of content on this online that's free on things like YouTube and stuff like that. What I do want to get into is actually how to set the teeth efficiently and kind of look at those tools and how to pick the right libraries for patients, because that seems to be the area that most people struggle with.
Yeah, there's hundreds of tooth libraries. So tell us, what are your favorites? Why are they your favorites? And how do you capture efficiency with them?
Yeah, so the libraries that I typically use the most are the Dentsupply libraries, just because the lab that I work at is a Dentsupply lab where we use the Lucitone products for the digital print. So we do typically use theirs. Now there are some other really nice libraries out there that I like to use every once in a while as well. One of the big ones is the Nobilium libraries.
Okay.
Part of the reason I like those is they're great because they're free. So there's no cost to use them. They're in the download center in your software, which is really nice. And if you're just trying to get into dentures, that's a great library to start with, to practice, setting teeth, doing a couple cases. And the other nice thing about them too is I like to use them for crown and bridge as well. The anteriors especially have some really nice, you know, facial anatomy. The posteriors have some pretty deep anatomy, and they're just really nice looking libraries as well.
Awesome. All right, so we got a nice upper lower cast scanned from the impression.
Yeah, so typically if I were setting this by hand, it would probably take me maybe an hour and a half to fully set these teeth, and do the gingival waxing on them. Whereas here in the software, from the very beginning of this case to the very end of this case, I'm probably 20 to 30 minutes tops.
Nice.
So and it's the software that does that for me. I mean, it's so efficient. It does a great job. So, and I have access to everything. One of the issues that a lot of people run into, especially with not just setting the teeth, but picking the right teeth molds and shapes for patients, is it's really hard to transfer that picture that you look at in a catalog of teeth to the physical models. Well, in here I have the advantage of, okay, well, this library looks pretty good. Let me throw it up there and see what it looks like in the patient's actual mouth or in on the models. And then I can say, oh, well, it's a little too big, or it's a little, I don't like this, or I don't like that. Then I just grab a different library and apply it, and it pops it right up there. So looking at this now, the first thing you're going to look through is your provider box, and you're going to determine which provider you want to go with. So this could be Dentsupply, it could be Ivoclar, there's Nobilium, there's hundreds of different options in here. So you can see all the ones that I have here. You can even make your own denture libraries if you want, which is really nice. So I know of some labs who waxed some teeth that they really liked, and they scanned them all in. They created a library, and now they use that for both crown and bridge and dentures, which is really cool. But there's also a lot of libraries out here that are provided for you. Some of them do have a cost. Some of them are free. So there's a lot to choose from, and it can get a little overwhelming. So you have to decide, what kind of mold do I want to go with? Do I want to go with a high degree of cusp inclination? Do I want to go with 0 or 10 degree teeth? Do I want, am I looking at a cross bite? Am I looking at class 1, class 2, class 3? All this is a factor still in which libraries you choose. The advantage to this, though, is that if I choose a library and I populate it on the screen by hitting the apply button here, it gives me all the teeth, but it doesn't just give me the teeth just set up on here. It gives me the teeth set in whatever occlusal type I chose. So if I chose, for example, this is a balanced occlusal library here, and I really look at these, they are set in a balanced occlusion as soon as I pull them up on the screen. So
Nice.
rather than me having to sit here and set each individual tooth and get it into a balanced occlusion, it's already done. So I'm not doing what I had to do when I would do traditional dentures. All I'm doing now is making this arch form fit this patient's shape and size of their arches.
Yeah,
So
I've heard from a lot of designers that designing a double arch case doesn't take too much longer than a single arch case
no,
because of that.
it's actually shorter because with a single arch case you have natural dentition that you're opposing. So you're changing little cusps and making sure
Yeah,
you've got contact with each tooth. Here, all the contact is already done for
it's
you,
perfect. Yeah.
and you're just making it fit the mouth. So you can see on here that I have, this library looks pretty good. So now I can actually come in here and I can overlay the original dentures and I can make them faded slightly. So now I can see right through them and I can see my denture teeth. So I can go ahead and move these and try to get them set to the exact position where they originally were. So, a lot of people want a one-to-one copy of things. You won't always get that. And you honestly, you really don't want that because a lot of times when a patient comes in and their denture doesn't fit anymore, but they like the shape and size of the teeth, it's just the shape and size of the teeth. The anatomy's all worn out of them.
Yeah.
They don't look nice anymore. They have no facial anatomy. So what I always try to do is I try to have my clinicians, or if I'm the one scanning, I scan in their existing dentures. I choose a mold shape that looks like their original teeth
Yeah.
but has more detail to it. So not only are they getting, a denture that looks very similar to their original, but they're also getting it with updated occlusal anatomy, facial anatomy, and better gingival anatomy a lot of times too. When you finish these dentures, you don't have to pumice and polish them anymore, which is really nice. That takes away a lot of anatomy as you're pressing with your pumice wheel.
Yeah.
You can actually use some sealer materials, like for example with Dentsply, they have the Step 3 Total, which you can paint over the whole outer surface of the denture and preserve all that nice gingival anatomy and tooth anatomy that you create. So there's a lot of cool things that you can do with these dentures to make them look just like the patient's, only updated with better anatomy.
Yeah, as long as the length and width and size of like the anterior six, if it's really really close, then the patient's really got brand new teeth, new anatomy, but it's going to be like a 90%, 95% match to what they walked in with, and they'll love it.
Yeah. And what they're really looking for is the same look in the aesthetic zone. So the aesthetic zone is typically when you smile real big, it's always going to be your upper and lower front six, but on top of that, it's where your occlusal plane sits as it works back into the mouth. So if you set your occlusal plane too high or too low in the mouth, then they're going to notice it and it's not going to be right. The
Yeah.
other thing that they're also going to notice is whether those teeth sit sunk in too much or out too far. So those are really the things that you have to watch for. So I could make, I could really actually make these teeth slightly bigger this way, and the patient really wouldn't notice unless they started biting a cheek or something like that. So you can also take their original dentures and correct things that weren't done right. So I've noticed a lot of original dentures where the anterior teeth look great, but then the posterior teeth that were chosen were too small and they don't fill the patient's mouth very well, but they were put out in the right buccal corridor so that they look right here. But when you take them out of there, this canine is almost 1.5 times the size of the bicuspid, which is way too small of a bicuspid. So you can correct some of that as well. The biggest thing here is to watch to make sure that you have your occlusal plane set very close to where their original one was. So that's usually the first thing I do is look at the occlusal plane, and then I'll look at the lip support because that's really important. If you don't have proper lip support, then the lip will look wrinkly and sunk in a little bit, and it'll
Right.
actually make the patient look older. So I always watch for that. And then I look at the original teeth and I look for wear. So if they're heavily worn, I'm not going to put the incisal edge right where that worn incisal edge is. I'm going to lengthen it a little bit because they were probably originally longer than what they are now. And it's such a gradual process over all the years that they've worn this denture that they haven't really noticed. But what they're finding though is that they're having trouble tearing food because there is no overlap on the anterior teeth. Now they're more like this, and so they can't tear teeth real well. They can't masticate food back here because their cusps are all worn away.
Yeah.
So you want to restore where you think they were. And you can choose libraries now based on just how they look versus with traditional, you had to set libraries based on the size and how they looked. So here I can come in here if I think, well, this looks a little smaller than what they had, I can just pull and make the library a little bit bigger so
Wow.
that I get the right widths. Same thing back here. If I feel like, well, let's say I feel like these are too long back here or too far back, I can just push them in and shrink them down a little bit. So now they have the right shape and size teeth that they're used to. If I want to move anything, so you can see here the anterior looks really nice. There's nice overlap between the teeth. I've got a few little rotation things that might be a little different here, which I can fix. But for the most part, the overlap looks great. The posterior teeth, they look like they're in a little bit, so I can fix that. Which another reason why this is so nice to have the original denture, I can come in with this middle tool here, and I can just kind of pull these and rotate them out and get that buccal corridor where it's supposed to be. So now that not only will they have the proper lip support, but they'll have the proper cheek support as well. And having this denture, if they've been wearing this denture for 20 years, that means they're probably not biting their cheeks or their lips or anything with the dentures. So that is the target spot to have those posterior teeth so that you don't create that issue.
Yeah, for sure.
It also, it kind of saves you from having to have additional data. So one of the big things that used to be was getting 3D scans of the head that you could overlay over the surface scans of the mouth so that you could see where the patient smiled and all that. Well, if you just have the reference denture, you can see all that from the original denture as long as the original denture was correct. So you just follow along with that and you've got everything you need to complete this denture. So I can go in here and I can make all kinds of little changes. Now, when I do mine, I start typically from this first tool here on the left. So this is your occlusal plane adjustment tool. What this tool does is it allows you to move the whole arch as one piece. So when I use this, I can't take this tooth and move it out of occlusion and that kind of stuff. All the upper and lower teeth are stuck together. So that helps us to move things into kind of the right position, get our midline set where the midline of the original denture was, and you can really kind of control this pretty nicely here. The other thing that's kind of cool about this tool is, let's say you do a try-in and the midline's off, and then you scan everything back in and you want to just shift the midline over a millimeter. When I grab this blue control point out here and I hold the mouse button on it, you'll see that there's a little value that shows up there. And as I
Oh,
move that, I can see, okay, well now I'm right at about a millimeter. So
nice.
I've
So you
just
know
shifted.
how far you're moving things in the mouth.
Exactly.
That's really good. That's really helpful.
Yeah, so you can make a lot of adjustments. It's also really helpful too for correcting length of teeth. So let's say you send this out to the doctor and the doctor says, well, the incisal edges might be a little too long in the anterior, and I think they need to be, reduced down a millimeter. So I can use this individual tool here, turn on my symmetric design, and then I can grab, let's start here with the centrals, and then I can just shrink that up a millimeter, just like what the doctor asked for.
And it moves
And
both teeth.
yep, and it moves both teeth. It keeps them symmetrical, and same thing here. So I can just work my way back through the anterior teeth and get them all shrunk up about a millimeter.
Nice.
Now, the same kind of concept would work too with, let's say you were you know, the feedback is that, you know, it's not the tooth that needs to be shortened, but the whole tooth needs to be moved up a millimeter. Well, it's the same concept. You can come here having symmetric design turned on, and instead of grabbing the green control point, you just grab the blue one and move those up a millimeter.
Nice. So yeah, it matters which control point you're grabbing and how it gets moved.
Yeah. Some of the other nice things about this is, so going back to the PLY file format, it does hold color when you bring those in, even if you bring them in from, you know, Itero or some other system. So the advantage to that is when you do the try-in phase, you get basically, you're going to print an all one color try-in. So it'll be typically a tooth color. The nice thing about that is on the clinical side, you don't have to move individual teeth around. You just draw on it where you want. So like if the midline's off, just draw where you want the midline with a Sharpie or an indelible pencil. If the teeth are too, let's say the patient's showing too much upper tooth and there's too much gum showing, you just draw on there where the lip line is. And then when you scan that back in with your intraoral scanner, it scans in that color. So when I'm overlaying here, I have a button over here on the side, on this side toolbar, where I can actually turn back on the real color and see everything that's marked on it. So I don't have one here, but you can see here where I can see the difference between the tooth material and the tissue. Those black lines that you draw on there would show up here as well. And then it just basically, you can do the exact same thing that I was just showing you. You fade it a little bit, and then you bring your teeth back in, and now you just move things to where those lines are, and you're done. Most of the time I actually spend more time on the try-in denture than I do on the final denture, because I put most of the work in there, and that's just minor changes to the final denture before I run through and reprint it.
With the reference denture workflow, my guess is sometimes, or maybe often, the try-in is perfect. Right?
Yeah. Yeah, it's really based off of clinical records. So if the clinical records are good and accurate, then a lot of the time the try-in is, I just get an email or a phone call saying, just go ahead and print the finals for me. I have one doctor that I work with in particular that's I would say 95% of their cases are that way, which is huge.
Well, then why don't you just make the try-in the final? So 95% of the time you skip the try-in.
Yeah. Well, the issue though with that is the cost. So let's say I do that, and then the denture I send them is not right. I've probably spent almost double what I would have spent on just printing a try-in.
Yeah.
Now, one of the advantages though with this is the way that I set up my orders. So I never set up a case as a straight try-in anymore. I always set the case up as a final, because with 3Shape, not only do you get the separated files, you also get the monoblock output, which is basically the teeth and the base in one file. So I just go in and I print that, send that to them as a try-in, and if they call me up and say, hey, it's good, let's go ahead and print the finals, I don't have to create a whole new case. I don't have to change anything. I just go back to that original case, pull the separated files, and go ahead and print them.
Well, this is actually a key point. I remember this from a few years back, that the way you set up an order at the beginning determines, the path you're going to go on and where you're going to end up.
Yeah.
And so what you just said is you really don't use the try-in workflow, you use the final workflow, but then you take the monoblock output as the try-in.
Yep.
And then when you want to go to final, if the try-in was perfect, the final design is done, and you're literally just outputting your files for printing the base and printing the teeth or milling the teeth or whatever.
Yeah, and it really doesn't matter how you set up your order form when you're going through these. So if you're doing multiple try-ins, you can still take a case that you set up as a final and reuse that try-in design from it on the next step if you have to. So just because I set it up as a final case doesn't mean I don't get access to that try-in workflow. I still can do that, which makes it even better. And a lot of times I do this workflow backwards as well. So if I'm doing a case for like an all on X, instead of sending them the monoblock first, I send them the final denture first so that they can wear that as an interim. And then I reuse the design with the try-in workflow. And then on the second case, I create it as a monoblock because I'm converting it over implants. So I'm typically taking that, milling it or printing it in one material, and then I'm layering like some kind of composite over the gingiva or porcelain if it's zirconia on the gingiva to create that pink aesthetic there. So you can use this workflow for many different things.
Nice. We'll have to do a different recording on some of your tips for All in X. I'm sure you got quite a few of those.
Yep.
So anything else to cover with library selection and manipulation? Any major pitfalls that you commonly see people get themselves into and time wasting things?
Yeah, so one of the things I always recommend when you go to set your teeth is you want to start here with the leftmost tool and work your way to the right. Try to focus on not going back and forth between tools. That's where you're going to spend a lot of time. And I do tell a lot of people to not even use this tool here on a full over full.
Which tool is this?
This is your morphing tool. So it allows you to come in here and you can, pull areas and change lining.
Why would you? If it's a full over full, these libraries are pretty awesome.
Exactly. So one of the things that people look at when they look at this is you can see how large this is on my screen. When you see this after it's printed out, it's going to be more like this. So try to focus on, when you're looking at this and you're, concerned about the way something looks, zoom out to about here and look at it. If you can't really tell, then no one else is going to be able to really tell. You want to try to eliminate as much actual design work that you're doing here as possible. If you can get it to where it fits in to where it should be using the larger tools, you really don't need to use the smaller tools. I can do a full over full in usually under 100 moves on every case I've done.
Wow.
Which if you think about, the crown and bridge module and dental system and how many moves you have to put on those, sometimes if you're doing a full over full, you're around 1,000 to 1,500 moves to get those completed, which is quite a bit. So, and you can see here, if I look at this denture with the original denture in place, and just kind of overlay them, they're very close right now to where the new teeth are very close to where the old teeth were, and I've only put 12 moves on this.
12.
So,
obviously, we got more work to do, but still, that's pretty awesome. You got
I mean it's not complete, but I mean it's pretty close. Some minor tweaking here and there. So I would probably say on this case, I could probably get this done in about 30 to 40 moves. So try to count your moves, try to eliminate things that you're doing too much of, try not to look at every little aspect of it. One of the big pitfalls with this too is a lot of people who are used to designing crown and bridge try to get into dentures and they do too much. They put too much work into it, end up spending 2 to 3 hours on one case, and then you've basically just wasted time and you're not saving yourself any time at that point.
Yeah, if you got a full over full case, I mean, obviously you do have some tooth manipulation, but for how many years were we limited to the shape of a carded tooth, right? And you just could move it up, down, left, right, and that was it. Obviously, there's more flexibility here, which is awesome, but these manufacturers put a ton of time and resource into making them look really pretty, making the occlusal setups really nice. And so, I think, taking advantage of that and not trying to overthink it, overwork it. It's really smart.
Yep.
Awesome. Well, thank you, Brandon. Any final comments on denture design with libraries?
I guess the best advice I could give someone to start with these. So don't start on your most difficult case. Um, that seems to always be what a lot of people do. They'll do all these easy cases analog, and then they'll say, well, this case, I don't know if I could do this analog, so I'm going to try it digital. And then it ends up as a disaster for them because they don't understand the workflow, they don't understand the tools, they fumble with it, and it just doesn't turn out real nice. So always try to start with your basic everyday cases first, get used to the workflow, get used to the tools, and then graduate up to more difficult cases. Your cross bites, your, class 3 cases. Start with some of the easier stuff so you can get used to it and then move up from there.
Sounds good. That's good advice. Really good advice. All right. If any of you want to reach out to Brandon, you can find him on rebel3d.com/Brandon, and he is there to help you one-on-one training, whatever you need. So, Brandon, thank you for being with us.
Thanks, Rob.
All right, buddy. Take care.
You too.